Okay, so we're going to go through the lab sections, chapter 19 and 20, I believe. And we're going to be looking at the knee and looking at the foot and ankle. And unfortunately, this book doesn't get into the foot as much, but there's outside of what we talked about during the live session on on Tuesday, outside of just kind of knowing the differential between forefoot and rear foot. And we kind of looked a little bit at forefoot inversion, right? So if this is your right foot, and here's your big toe, your hallux, and then here's your pinky toe, your fifth digit, and you're looking at the bottom surface of your foot. So someone's laying down. When that calcaneus here, this is the calcaneus. When this turns this into inversion, this is looking at what's referred to sometimes as pronation. So you have calcaneal inversion, and that's triggering movement through the midfoot as well. So we're going to show some of this today. We looked at most of this in open chain. So when the rear foot's inverting, so is the forefoot. And when the rear foot's inverting, so is the forefoot. And which is fine in open chain. Remember, open chain is when the foot is free, so it's not bound by the earth or friction. And what we're going to look at is in closed chain now is what's going to happen with that inversion and then this eversion. So in terms of the plantar fascia that we talked about and all the different connections, there's really not much. It's more of understanding global foot function. This book really looks at the ankle and the foot as a black box and not really looking at a lot of separation there, which is fine. It's very common in kinesiology books. It does look a lot at the proximal end of here's your tibia and fibula and looking at dorsiflexion and plantar flexion, not how we traditionally look at plantar flexion and dorsiflexion. We usually look at dorsiflexion as the foot moving relative to, right? So this would be ankle dorsiflexion. This is the dorsal surface of the foot moving closer. So the angle between here and here is getting closer. And then plantar flexion, plantar, which is the bottom surface of the foot, this is getting closer and closer in terms of the back. But that's just looking at dorsiflexion, plantar flexion, open chain. What we're going to look at is analyzing during a lot of the functional movement that you'll be doing or exercises, how that looks in terms of the tibia moving forward closer to the dorsal surface. So this is dorsiflexion, so is that, right? This is plantar flexion, so is that. So we'll look at a lot of the functional stuff today. The big thing that I'm seeing in both these chapters, 19 and 20, and which are going to appear on the exam, is this understanding of passive insufficiency and active insufficiency. And it's really important for us to understand that because as a practitioner, where you're imposing forces and stresses onto the body, to be able to differentiate or play, not games, but modify or manipulate exercise because of what you can do at one joint, shortening a joint. So like, for instance, if we look at the knee, you can adjust length of the gastroc based on knee position. And if you're trying to stretch the gastroc because you have tight gastrocs or tight calves because there's some limitation in ankle dorsiflexion, how can you manipulate your knee position so that you can emphasize either soleus or gastroc? And so we'll be doing that today too, looking at the different passive and active insufficiencies. And so I would remember this is being recorded, and if you're lost a little bit today with the passive and active insufficiency, go back to maybe the video from the first unit where we talked about muscle length and active and passive insufficiency, because it's going to pop up again on this, particularly in the lower body, because that's where we do a lot of the rec fem, the hamstring group, and the gastroc. So let's go through and start with let me see, pull this up here. And again, if we were in class, we would be doing a lot of the palpation aspect in the lab, especially for the foot. The lab is a lot of palpation and trying to find superficial anatomy, and it's really good to help with the learning process, but it's not doesn't lend itself to really an online environment. So don't worry about so much of those questions and aspect, but we're going to start with, I have my page marked here. This is the hip, the knee. Okay, so chapter 19. All right, so we'll start with number 7, but let me just check at 5 real quick. This is on page 232. I kind of did 6 the other day where we looked at like the convex and concave surfaces of the leg. Let me grab my other models here. When you look at the, here's the femur, and there's your distal end of your femur there. Make sure I put this down. Get the camera. Just optimize my workspace here. Okay. So you're at the femur, you can appreciate that it bows out a little bit. There's a rounded aspect. So this is the convex surface, and then the tibia typically has the connective tissue. You're going to have your labrum there. You're going to have your meniscus, your medial and lateral meniscus, and they're going to form like a cup or a socket for that femur to kind of rotate in. So here's your convex surface, concave surface, and just make sure that you are up to date in reviewing your roll and glide. So when you have the convex surface moving, this has a tendency to kind of roll. If this was here, it was going to roll off, and so you need to have a glide to pull that back. So the roll and glide are going to happen in opposite directions. But now let's say it's a knee extension or knee flexion. You kind of see what I did there is when I tried to come up, I'm running out of space. So as I'm rolling, I need to kind of move and glide in the same direction to kind of keep up. And what you're trying to do is keep that line, that joint congruency. When you look at number 6, it's kind of going through the different convex, concave. So there's just a little reminder there. But number 7 is where we get into the muscle length aspects here. And when we look at the posterior chain here,
I was wondering, could you make your picture bigger?
My picture bigger? What do you mean?
Yeah, like enlarge your picture. I know Rita does it a lot because you're small and you can't really see what you're doing.
I think that's setting on your end, no?
Oh, I don't know how to do that. Okay, thank you.
Did I do it? Did I do it?
No, I don't think so. I don't know. I think there's a way you're supposed to be able to make it bigger. If you can't, it's fine.
In the top right corner, there's an option to change it. You can change it to a thumbnail video view, and it makes the active person like the full screen.
You're talking to Susan, right? Not me?
Yeah, Susan, yes. Yeah.
Okay, yeah, it's on her end, correct?
Yes, it is.
Okay. Now, I know I set it up for the recording so that because I know last time the recording screwed up, but now I have it recording where it's going to be just my screen and not everyone else. But for the display right now,
I figured it out. Thank you.
Perfect. And thank you for whoever offered that. But now I screwed up my thing because I was messing around with my... Okay. Come on. Susan, you took me off my thing here now. So I can't see.
I'm sorry.
You didn't do it. You didn't do it. I'm just giving someone to blame my frustration here. Okay. All right, so when you're in this situation here like this, you have the hamstring. The hamstring it crosses at the hip, and it comes down here and crosses at the knee. And so if I want to maximally lengthen the hamstring, I need to full knee extension, and I also need to do full hip flexion at the same time. So this would be assuming someone's laying down on their back. And if we were to be in class together and we were looking at like hamstring length, I would have everyone, we would lay on our back and we would look at where would be the least flexible and where would be the most flexible. And when we look at our leg raise, our most flexible would be if we're laying here and I try to bring your knee to your chest and I allow you to bend your knee as much as you can. And if you lay on your back, I would be hard pressed to find anyone that wouldn't be able to bring their knee almost all the way up to their chest, right? If we do that same thing, we lay on our back, but we discipline and we keep the knee totally locked, you're going to see a different amount of range of motion. We would see, I know if I did it, I'd be about 50 or 60 degrees, right? I wouldn't get full hip flexion. And some of you guys would be 90, and then some of you freaks would get past 90 and up to 100 and 120, but you would have significant tension. And the joint action in that situation is the same. Whether I'm bringing the knee to the chest like this and I'm doing hip flexion, or I'm keeping the leg straight, it's hip flexion nonetheless. What's different is the hamstring length on the antagonist or posterior side. When you keep the leg straight, you are shortening you're lengthening at the hip while also lengthening at the knee, and so you're rapidly getting the tension limit of that hamstring. So you're becoming passively insufficient, right? Because you are lengthening both at the knee and at the hip, and so now when you get to that end range, you're passively insufficient. Your hip can't go any further into hip flexion, and so you hit the brakes. Now, in order to get more hip flexion, what I can start doing is bending at the knee, and you can see that the rubber band, the tension is loose, and now that gives me more range of motion to pick up at the hip. So that is and eventually now I'm going to hit passively insufficient, but I'm going to do it with further hip flexion because I yielded a little bit at the knee. So that's an example of how a range of motion or movement would change based on the biarticulate nature of a particular muscle. So the hamstrings do that with hip flexion, knee flexion. And then the rectus femoris, which is part of the quadricep, that does that on the anterior side when you look at hip flexion, knee extension. So when you look at the knee extensors, you have your quadriceps, you have the vastus medialis, vastus lateralis, and vastus intermedius, and all those muscles are monoarticulate muscles that originate here on the femur, and they come down, and all four of the muscles, they converge down to the patellar tendon, and they come straight down here and they attach to the tibial tuberosity. So the one muscle that's the oddball of the group is the one that's named differently. It's not the vastus muscles. Vastus muscles only cross the knee, and that's all they do, but it's the rectus femoris muscle. And the rectus femoris muscle originates here on the hip, on the AIIS, and it comes down, and it's a pretty decent hip flexor, so it can bring the leg forward into flexion. And it's actively insufficient position. Oh, I guess we didn't talk about the hamstring, but we'll talk. I'll go back to it. But the actively insufficient position is a joint position where the muscle is the most shortened. Passively insufficient is when the muscle is the most lengthened. So if we look at the most shortened position for the rectus femoris, that would be full hip flexion and full knee extension. So that would look like you trying to do a straight leg raise as much as you can, which is also the same position for the hamstring in its passively insufficient position. So if I'm actively insufficient, maximizing my active insufficiency for the rectus femoris on the anterior side, at the same time, I am maximizing my lengthening or the passive insufficiency of the hamstring. And then the roles are reversed. If we look at the maximally lengthened position for the rectus femoris, that would be full knee flexion and hip extension. So the way this would look is be someone laying down on the table like this, and they would try to bend their knee as much as they can, and then they would kick their leg up in the air and try to do maximal hip extension, like a donkey kick, think of like that. And so what I'm doing in this position, then I'm maximally lengthening here the rectus femoris at the hip and rectus femoris at the knee. At the same time, I'm maximally shortening my hamstring, both at the knee as a knee flexor, and then both at the hip as a hip extensor. So they're tied and paired together. So hopefully that makes sense. Now, how would you use this in exercise selection or changes? And I think I went over a little bit last week, but just review it again in the context of active and passive insufficiency. The knee and the gastroc work together. I'm sorry, the hamstrings and the gastroc work together at the knee, and the hamstrings and the glute max and the other hip extensors work together at the hip. And if I wanted to, let's say, isolate or target the glute max muscle, and I want to do it through hip extension. If I stay in this position here, where I'm both muscles are going to be shortening at the hip, trying to pull the foot up into the air, but the hamstring is going to be able to maintain its mid-length position, which, as you recall, is the strongest position, because as I'm shortening here at the hip, I'm maintaining my length at the knee, so it still has a decent range of motion to contract. So when I look at the EMG activity, I'm seeing hamstring and glute involved in this activity. But if I wanted to, let's say, disadvantage the hamstring to make the glute perhaps do more work, what I can do is I can flex the knee. So what I'm doing is I'm pre-shortening the hamstring, already taking it from its mid-range into a shorter position. So then as it goes into hip extension, the muscle is getting even shorter. And as I get closer and closer to its actively insufficient position, the force or the tension is rapidly dropping. And so in this position, the hamstring is able to contribute to a fuller range of motion. So the hamstring and the glute are equally doing the amount of work. Whereas in this case, as I bend the knee and I go up, as I'm going up further, the hamstring is getting less and less participating, or is not able to contribute as much, making the glute max do more of the work. So that's looking at how do you manipulate active and passive insufficiency from an activation aspect. So with active insufficiency, if you can give the muscle a disadvantage, you would force the other muscles to pick up the slack. And then the other way that you would use this is in terms of, like, let's say, stretching. If you wanted to stretch the hamstrings, and because you felt like that tissue needed to be extended, there were some extensibility issues with that. I'm here like this, and I needed to lengthen that. You don't want to stretch the hamstrings and have your knee bent, right? In fact, if you think about when you're stretching patients or clients' hamstrings, the one thing they want to do is they want to bend their knee a little bit because it feels better, right? They're taking them out of that position, so you want to make sure that the leg's locked. And so if you're trying to stretch muscles, you're going to put them as much as you can in the passively insufficient position. You're going to try to maximize their length before you start to put force into there. So if you wanted to stretch the hamstrings, you would try to do it in a way where if you're going to stretch them at the hip, you're going to try to keep the knee as locked as much as possible and try to do a straight leg and really have the client or patient keep their knee as straight as possible. Think about for a second how you would stretch, let's say, tight hip flexors, and you weren't going to stretch the iliopsoas, but you were going to stretch the rectus femoris. Now, you don't have to answer, but before I give you the answer, I just want you to think, because this would be like a test question. What would be your starting position to stretch the rectus femoris would be the question. And if you want to kind of take a couple seconds and work through that. So if the rectus femoris, its action is a hip flexor and a knee extensor, that's, if you were to do both of those, that would put you in the shortest position. Think about the position you would have to get in to fully lengthen it in a passively insufficient position. And you would have someone lay supine on the table, so this is the foot's face down, and you would have them bend their knee as much as that you can. And then while on the table, you would take their leg and you would try to lift up into extension, and they would feel a huge stretch right in the front of the right in the belly of the rectus femoris. Now, if you were to let them extend their knee a little bit, they would get a lot more range of motion, but the more they shorten at the knee, the less range of motion they're going to have here at the hip. If we were in class, I'd have someone on the table, or if we were in, I just don't have a live participant, and the skeleton doesn't have a lot of muscle on it. So hopefully that makes sense with how you would manipulate active insufficiency for strengthening exercises and rely on passive insufficiency for stretching exercises. I'm going to jump ahead because we're on the topic, but it also happens with the ankle-knee relationship. So this is in the next chapter, but we'll do it now, and you can fill in the gaps. Ankle dorsiflexion is a big part of mobility, particularly the ability to do a deep squat. And I think Natalie had shared with me that you guys in one of your classes, you found out how much dorsiflexion is needed for a deep squat, and you get a lot of people inability. If you think about when you're squatting, what's happening is that the knee is going forward, and as the knee goes forward, it's pushing your center of mass forward because your body's trying to keep its center of mass through the base of support, which is the footprints that are made through the feet. And so as I come forward, I need to shift that. And if I can't, what ends up happening is that heel starts to pop up off the ground. And so you go from a nice stable surface to an unstable surface. And so what people end up doing in order to compensate for lack of ankle dorsiflexion, instead of staying in the sagittal plane, they'll take a wider stance and they'll rotate out so they can do more ankle supination through the subtalar joint and the mid-tarsal joint. So that's a compensation you'll see. Is you'll see people take a really wide stance because they lack the ankle dorsiflexion. Well, one of the primary restrictors of ankle dorsiflexion is all of this musculature, the triceps surae here in the back, right? So you have your gastroc, your two head, medial and lateral heads of the gastroc, and you have your soleus underneath there. And then don't forget your posterior tibialis, your flexor digitorum longus, your flexor digitorum hallucis. All of these muscles are also plantar flexors because these are all extrinsic muscles that originate up here and they come down and they cross the ankle joint and they attach down here in the foot. So you have quite a bit of musculature that's dedicated to plantar flexion, and you only have a few muscles that are dedicated to dorsiflexion. So really only tibialis anterior and extensor digitorum longus and extensor hallucis longus. That's it. Outside of that, everything does plantar flexion. But by and far the biggest muscle bulk of your plantar flexors are your gastroc muscles, and then the next biggest is your soleus. All of those aforementioned muscles, they all cross the ankle and the ankle only. And then some of them do cross the subtalar joint, but the soleus only crosses the ankle. And so it originates, remember the gastrocs, the two heads of the gastroc and the soleus, they become one with the Achilles tendon, and the Achilles tendon comes down and attaches to the calcaneus. But now it's the gastroc that actually comes up and crosses the knee. So when you look at your let's say your ability to stretch your leg, a lot of times people do ankle dorsiflexion and they do it in a knee locked position. So you'll see people go up against the wall. I'll be able to do it, but you'll see them, they'll go up against the wall and they'll kind of push against the wall and they'll keep their legs straight. And what they're trying to do is they're trying to like stretch their gastroc, their calves, right? But what's happening here is because the gastroc is a knee flexor and an ankle plantar flexor, that you are maximizing the muscle tension through the gastroc. And when you stretch this way, you are 9 times out of 10 mostly stretching the gastroc muscle, right? And if you wanted to try to stretch these other tissues here, the ones that are below the knee, like the soleus and the posterior tib, you would actually need to bend the knee a little bit. And what would happen is you would actually get a little bit more ankle dorsiflexion, but you wouldn't be stretching the gastroc anymore at this point. What you would be stretching now is you would be stretching, this is what I wanted to do. Sorry, give me a second. Okay, so if you're here, and you have your gastroc that's crossing the knee and it's coming down here to the calcaneus, and I go into that that straight leg stretch, it is all my ankle plantar flexors are limited, but the one that's the most limited because I'm maximized at the knee because I'm passively insufficient is the gastroc. You guys can see that. Good. All right, and so now in order for me to get more range of motion here, what I would need to do is I would actually need to bend the knee, and the evidence, the science around it shows about 20 degrees of knee flexion. So that's all you need, about 20 degrees of knee flexion. That's enough muscle slack for you to go a little further. And now what you're putting stretch on are all the monoarticulate muscles that only cross the ankle joint. So that would be the soleus, the posterior tibialis, and any of those other flexors. But typically it's the soleus that has more of the type 1 muscle fibers. These are the ones that are more of your endurance fibers. So the soleus comes on mostly during gait, whereas the gastroc's going to come on during gait as well, but those have more of your type 2 muscle fibers, your force producers. And so if people just stretch their calves all the time and they do it with their legs straight, which is how most people stretch, they're only stretching the gastroc and they're missing the soleus and those other tissues. And so bending the knee a little bit and then going further into a stretch, it's a deeper stretch because it's going to hit more of the muscles that are deeper towards the attachment sites there. And it's a totally different aspect. But again, from a clinical aspect, this is all great. The functional aspect from this is that it's playing on the differences between active and passive insufficiency. In this case, I'm passively insufficient at the gastroc, and it's keeping me from going further into that motion. So I want to, if my goal is to maximize the amount of ankle dorsiflexion I have, I'm actually going to bend at the knee to give slack in the muscle length so that I can get more of it at the ankle. So you're just kind of redistributing or repartitioning where you're getting that motion at. And in this case, it's not just one muscle, it's the gastroc that's preventing you from actually stretching those other muscles that happen across the ankle only. Any questions? Okay, so active insufficiency is maximally shortened. Passive insufficiency is maximally lengthened. When you're maximally lengthened on one side of the axis, you're also going to be maximally shortened on the other side of the axis, right? And it doesn't have to be biarticulate muscles. You guys understand this from muscle function that the agonist, in this case, the biceps are bending the elbow. And so as my biceps are shortening, my triceps on the other side are lengthening. And then they switch roles. The agonist, the triceps are shortening and the biceps lengthening. So if I'm maximally shortened here, that means I'm maximally lengthened on the other side. And in this case, we're dealing with the lower body. You're dealing with like the hip, the knee, and the ankle. Perfect. And number 8 is kind of a review from the genu varum, genu varus. Remember, this is looking at the frontal plane alignment. So if you're looking at the frontal plane here, you have a proximal and a distal end of each of the segments, and that proximal and distal relationship happens at all 3 joints. You have the hip, you have the ankle or the knee, and you have the ankle. And when you're talking about varus or valgus, you have to be specific about which joint you're talking about. We would never say that you have a varus leg condition because the leg incorporates 3 joints. You would never say you have a valgus leg condition because that wouldn't make any sense. A valgus leg condition would mean that like your legs are crossed all the way over. You know, what you're usually referring to when you're talking about varus or valgus conditions, you're talking about specific joints. So you're talking about the hip, or you're talking about the knee, or you're talking about the ankle. All right. And so each joint has a proximal and a distal end of a bone. So your hip joint is the proximal end of the femur with the distal end of the pelvis. Your knee joint is the distal end of the femur with the proximal end of the tibia. And your ankle joint is the distal end of the tibial calcaneal aspect and the proximal end of the rear foot, the calcaneus. So what the valgus or varus is talking about is what position is the distal end of the segment in. So a valgus knee position would be that I think I remember telling you guys that the way I remember it is valgus with the G-U-S, gus, I think of gum. And the gum, you have the 2 parts sticking together. So that means the distal end of the joint would be in. So this would be more of your knock knee position where the knees are kind of going in towards each other. So if I'm looking here, I have I'm relatively neutral and I'm going, if my knees are coming in, meaning that, which would mean that I'm varus at the hip, I'm valgus at the knee. And the reason why this is varus at the knee is because there's gap or space, there's air in between there. If I go varus at the knee, that means I have the distal end is out more. That'd be varus and if I look at now the relationship here, a varus knee condition is kind of creating maybe a quasi-valgus hip position, but more importantly, down at the foot, because you don't really look at varus or var at the hip. It's usually looking at knee or ankle. But if I'm here and I go in at the knee, like I dive in, you can see that my foot actually turns out a little bit. So a valgus condition at the knee, if I'm not kneed, is creating a varus condition at the ankles. And then conversely, if I do a varus condition at the knee where the knee's kind of bowing out, like you're bow-legged, that's forcing the distal end in, creating a valgus at the ankle So valgus, the distal end is sticking together, valgum, right? And then a varus, the distal end is out, creating space between the joints. So that's the kind of the premise of 8. Remember, number 9 is the Q angle. Q angle is looking at the quadricep angle. You're looking at the line that goes from the ASIS and going straight down through the patella. And you can see that the femur has kind of its proximal end is out a little bit, so the legs kind of go in, which is why the medial condyle is larger, and that's why you have more of the injuries. And then the Q angle basically is allegedly larger in females because the horizontal distance between the heads of the femur are larger because of the wider pelvis. And so that has been thought, it's no longer prevailing theory, but has been thought to be the issue for why young women athletes have a high rate of ACL injuries. Usually just due to muscle function and muscle control. But that's what the Q angle is. Number 10, and I'm probably going to show up a picture here. Typically in the elbows and the knees, you have 0 degrees of extension is considered normal. But there are some people that have a little bit of what's called hyperextension, and where they go a little bit beyond that. So like they would lock their elbow out and it would actually hyperextend a little bit. Sometimes in grade school, people would call this being double jointed, even though there's not 2 joints in there. And you know how I feel about the textbook using the term hyperextension to talk about extension. But in this case, this truly is hyperextension. And it's called genu recavatum. And I'm just going to pull up a couple images. And I'm sure there's like some classic anatomy people that like to gross people out in this. And let's just let me just share my screen real quick. And so you can see, like in some of these pictures here, there's just a little bit of hyperextension, and about 5 degrees is considered normal for most. But you can get some really severe like situations. So this is her anterior, right? So she's bending as much at her knee as she is, like most people would do with flexion in the back, right? So this is here you can kind of see better. You can see it's like a hyperactivity of ligament laxity. In the upper extremity, it's not such a big deal, right? You would see it in the elbow and the arm, and not a big deal because you're not load bearing through there. So you just have this weird parlor trick that you would show and gross everyone out and say, hey, look what I can do. In the lower extremity, it's a little different because we're load bearing. And so this little bit over time can end up becoming more problematic. This is something that gets worse condition wise, and it eventually necessitates the need for a knee replacement. Sometimes some surgery can be done a little early on. Remember that when we're standing, and this is one of the primary things of what you're trying to do when you're working with patients that are post-op knee replacements, is everyone's so focused on trying to get knee flexion, knee flexion, knee flexion. But really, you want to get to knee extension so that you're locked out. Once you're locked out, your muscles are off, right? The muscles only come on a little bit, but once you're locked in this position, the ligaments, and so you're conserving energy. But if you're not able to fully lock out and you're slightly bent a little bit, you are developing muscle tension to maintain your upright posture. So the goal is to get that locked out position. And these people that have these hyperlaxity in the knee, or it's due to structure, it's due to ligaments. In order for them to lock out, they need to they're kind of put in tension. You can kind of see these images are grainy, but you can kind of see what we're trying to show here. Let's see if I get it better. And again, 5 degrees is normal, but you will end up seeing people with pretty extreme situation like that. Yeah, like this is. Show me a big picture. Whatever. You guys can see, like you can see that angle there. It's beyond 5 degrees. You can't see my screen?
I don't think we can see your screen.
Oh, what the heck? Share screen too. It says it's screening. How about now?
Yeah, you're good.
So it wasn't before, it is now? Okay.
Yeah, now it's showing. It wasn't before.
Okay. So all that talk, just apply it to these images. So, all right. So you can see here, remember, I can't see the chat function as well. So if something's going on, you guys got to speak up here. But I appreciate that. Thank you. So here's the genu cavatum. You can see the a little bit of hyperextension. A little bit is like up to 5 degrees is normal, but anything beyond that becomes more problematic. And you can see that it gets really severe in these type of cases here, where you have this is the anterior view, and this woman's getting as much hyperextension in the knee as most people get in knee flexion, and that's what happens over time with the loading. And sometimes they try to correct it with orthotics, maybe some surgery, so that it doesn't continue to get worse. And what ends up happening is that the constant jamming of that extension, it starts to loosen the joint capsule. The tissues that are plastic start to get more stretched out, and they're non-contractile. And I mean, you can get some really serious cases of more like Marfan syndrome and other types of ligament aspect. Never usually get that bad, but it does get to the point where you end up with like degenerative knee and necessitates like a knee replacement. You'll see it like that, where it'll just be a little bit, right? And I'm sure 1 out of 10 of you probably have this in class, and you have a little bit of hyperextension in the elbow. And in the upper extremity, not a big deal because you're not load bearing. But when you are in the lower extremity in the knee, it can become an issue there. So a lot of times what happens too, it's someone that ends up going through surgery and they get a knee replacement and they are fully extended and locked out on the right leg. And they still, because not a lot of surgeons are doing bilateral. They'll do one and they'll wait 6 to 8 weeks and then do the other one. I'm sorry, wait 3 to 4 months and then do the other one. And you have some patient problems where they're fully straight on the right leg and they truly have a leg length discrepancy. And then they also realize how unstable they really were from that. So you'll see this. It's not uncommon. What's uncommon are these freaks here when you see things like that. But you will see pretty commonly a little bit of hyperextension. And usually if it's in one side, you're going to see it in the other. It's an anatomical aspect, so you'll usually see symmetry. But if you only see it in one side, then you'd be questioning, like, was there some kind of like car accident trauma, like a PCL tear or something to that effect. So that's number 10. And I think that's going to be it. I think we're going to go through, we're going to hold off on 11 because we're going to talk about it with the ankle. As you can tell, we talked about with the hip last week, the hip and pelvis, they're looking at this ability to go in and out of a squat. If you want, like here, I'll be honest with you. When you look at lower extremity functional assessment, and when you look at like what people can do, when you look at exercise, there's only, let me stop my screen here for a second. When you look at lower extremity function, particularly when you look at exercise programming, there's only one thing the body does in the lower body, right? Which is triple extension, which is the ability to go from a deep squat, right? So ankle dorsiflexion, knee flexion, hip flexion, to triple extension, which is ankle plantar flexion, knee extension, and hip extension. So going from a sit to stand. And when you think of all the exercises that exist, all of them, and all the functional activity that exists, it's all that. Whether you're climbing stairs, walking, sitting from standing, if you think of exercises, whether you're doing a squat, a deadlift, a leg press, unless it's outside of some isolated aspect, all the lower extremity function is analyzing this motion. So when you're preparing, if I was studying for this functional anatomy exam or for my boards, I'd make sure that I know what eccentric loading for this motion, sitting, squatting, and the opposite motion of standing extension, right? So this is your eccentric phase. Don't forget that this is, you're seeing knee flexion, hip flexion. The hip flexors and knee flexors aren't working here. It's the hip extensors and knee extensors that are working eccentrically. And then this is your overcoming gravity, your supination, or your concentric phase of ankle extension, knee extension, hip extension, right? And then if you know that really well, you basically, it doesn't matter if it's saying walking down a step or doing a lunge or doing a squat or sitting from a sitting, standing, or climbing a ladder. It's all the same shit. It's all triple extension, eccentric loading on the way down, ankle flexion, knee flexion, hip flexion, and then concentric on the way up. It's not like the upper body where you have all like pushing, pulling, reaching, doing different things. The lower body is as simple can get. So if you were going to memorize and know it in or out, that's what I would do. Right. So then you don't have to worry about analyzing a lunge exercise or analyzing a squat exercise or analyzing functional mobility of climbing up and down stairs. You just relate it to this, right? This triple flexion, triple extension, triple flexion, triple extension. And we're skipping this for now. We're going to do some of the ankle stuff, and then when we get to the ankle, we'll integrate it all three: the ankle, the hip, and the knee. I think that's it for the knee. So the passive and active insufficiency and the different conditions of like genu recurvatum, valgus, and varus. Oh, and then also the knee. If you're in this position here, remember, we think of the knee only as flexion and extension, but don't forget that there's rotation that occurs here. There's actually a really important part of transverse plane motion that needs to happen for this lockout. Excuse me, for this lockout position. And if you guys all sit in your chair right now and you watch your foot and you lock your knee out, what you'll notice is you lock your knee out, you'll see a little bit of external tibia rotation. And what's happening is that is just you're maximizing joint congruency or connection between the femur and the tibia. And it's because of that size differential of the femoral condyles, right? The medial condyle is much larger and longer than the lateral condyle, and that comes from the hip being angled a little bit. You can see that when that's flat, when these condyles are flat, you're accommodating that wideness at the pelvis, right? You get the bones here and they're spread out a little bit and they're coming down at an angle, more pronounced in females because of the Q angle than males. And so then how that plays out with knee extension is that when you are locking your knee out, in order for you to get maximal joint aspect, when you're locking your leg out, you're going to get a little bit of external rotation, which means that when you go to bend your knee, when you unlock your knee, you need to internally rotate first and then come through. Don't forget that the muscle that does that is the popliteus, right? So that's what the popliteus muscle is doing. It's that other muscle that's behind the knee that crosses the knee. It basically does that internal rotation aspect, okay? Now, this is where it can get a little confusing, is that in open chain and closed chain, you're going to get different biomechanical analysis, right? Remember, we said convex concave is different. So is this rotation aspect. So when I'm in open chain, so let's say you're doing like a leg extension, you're sitting there, your foot's free to move and you kick your leg out. What's going to happen, so this is a right leg, as I go into full extension towards that end, I'm going to get a little bit of that external rotation on that lockout. And then to unlock, I'm going to get internal rotation and go into knee flexion, right? So that's the tibia moving relative to the femur. So again, extension, external rotation on lockout, and then internal rotation from the popliteus on the unlocking of the knee to go through knee flexion. Right. Now let's say I'm doing a squat, and now I have my tibia secure, and now my femur is here, and my femur is moving, right? The tibia is not going to rotate because the tibia is connected to the earth because your foot's on the ground and your foot's not going to move. The end that's more free to move now is the femur. So the femur is going to be internally, externally rotating. Same musculature, but it's just that inverse action because of closed chain. Now, external rotation of the tibia is the same as internal rotation of the femur. External rotation of the tibia is the same as internal rotation of the femur. So what happens in extension when the femur is moving relative to the tibia, instead of the tibia externally rotating, the femur is internally rotating, creating the same lockout. In order to unlock, so when you go to initiate your squat, you, instead of doing internal tibia rotation, you're doing external femur rotation so you can do flexion. So keep track of what I said there. In normal knee lockout, because this is transverse plane motion, when it's open chain, so when the foot's free to move and the body is more the static position. At terminal extension, you're going to get a little bit of, terminal extension, you're going to get a little bit of external rotation. And then when I go to unlock the knee into knee flexion, I'm going to get a little bit of an internal rotation, and then it's going to come through. If the femur is moving relative to the knee, it's going to be opposite. On extension, it's going to be internal rotation, which is the exact same thing as creating external tibia rotation, but the bone that's going to be moving is going to be the femur, not the tibia. And then when I go to unlock, it's going to do a little bit of external rotation, and external rotation of the femur is the same as internal rotation of the tibia. It's coming down. So population is still there. It's just appreciating which one's moving. And I know there's I have a couple, and I kept them in there because I think it's good questioning of understanding this inverse action of like whether you're talking about convex concave of open chain versus closed chain, or about this screw home mechanism of internal external rotation of the tibia fibula. Cool. No questions on that? Okay, so if you flip to page 255 now, yeah, there's like, I would love to do number 6 with you guys in class, because just to get you guys to get your hands on people's feet, and not to make you lovers of feet, but just to appreciate like when people have hard time squatting or standing or just having balance or have a history of falls, so much of this is tied to lack of ankle dorsiflexion. And ankle dorsiflexion, as we said last week, is a product of the tail curl joint, the ankle joint, and it's also part of this mid-tarsal joint as well. So you're getting dorsiflexion here, and you're getting dorsiflexion here, right? You get 2 points. And it's sometimes important, like if people have limited dorsiflexion and it truly is coming from the ankle, then by all means, you might need to stretch that. I would probably be looking more at strengthening. But if your ankle tail curl joint motion is fine, most of that might be coming from the arch, right? You might be too collapsed and you can't dorsiflex, and you need to have more like intrinsic foot musculature. And there's different ways that you can kind of lock and assess for dorsiflexion, but like going into inversion and testing dorsiflexion, and there's a lot of neat things you can do. Just don't think of a dorsiflexion as such a simple thing as just the ankle. Just appreciate that it's complex and it's coming from multiple parts. And if you really wanted to do your clients or patients a service, you would truly understand the interrelationship of the 3 joints down here and then up the kinetic chain. So again, it's a lot that we can't do in class, but stuff that just plant the seed for now and then research on your own. Okay, so number 9. Number 9 gets into what I was talking about at the beginning of class here. And what it's meant to do is take you through some analysis of the ankle. And what it's really doing, let's do this. What it's really doing is helping you appreciate ankle motion beyond just the dorsiflexion. Oh, oops, this guy's falling apart. Beyond just looking at like dorsiflexion and plantar flexion, which is easiest to assess. So if we put our foot up and we look at like our toes coming up, that's dorsiflexion, plantar flexion, right? Dorsiflexion, plantar flexion. And it's easy to see that because we know that the dorsal surface of the foot is coming closer to the shin, right? So this is getting closer. This is dorsiflexion. And then the bottom of your foot's the plantar surface. When I point this way, the plantar surface is getting closer to the shin. This is dorsiflexion, right? That's why we don't use the terms flexion and extension, because when we look at truly flexion and extension, if I look here, flexion is 2 joints getting closer together, approximating. That means it would be this side, but really the ankle joint is back here. So this actually is ankle extension. This is ankle flexion, right? But it gets confusing. And about 75% of textbooks get it wrong. So Actually, 25% get it wrong. Who knows? But it's inconsistent. So we talk about plantar flexion, dorsiflexion. So now the unfortunately is we're outside of being on and off the gas pedal, we're not in this position a lot. Most of the time, our foot's solid on the ground. And so ankle dorsiflexion and plantar flexion looks much different. So if I'm standing and I just lean forward, right? I just lean forward a little bit. I produced ankle dorsiflexion. Okay. Same joint action here, but instead of the foot moving relative to the tibia was moving relative to the flat foot, right? So I'm going into ankle dorsiflexion. Same thing if I lean back. If I lean back, that's the same as ankle plantar flexion, but instead of the foot moving relative to the tibia is moving relative to the stable flat foot, okay? Where you're going to see this the most is what I had said earlier, is when you're doing squatting activity, right? And you probably have heard the gym myth that you shouldn't let your knee go over your toe in squats, and that is absolutely incorrect. If you have long femurs, in order for you to maintain upright posture, your knees are going to have to go over your toes. And why that's important, what's the most important thing is that if I let my knee translate anteriorly, go forward, at some point I'm going to hit my passively insufficient length of the gastroc or the soleus, and what's going to happen is that's going to pop the foot up, and so your heels are going to come off the ground. And if you guys all deep squat and you see people with limitation, what they'll do is you see a lot of people with their up on the balls of their feet. You'll see a lot of people in the gym accommodate dorsiflexion by putting a little wedge or like a 2.5 pound plate or like a little 1/4 inch or 1/8 inch elevation. And it's actually a good thing to do to help accommodate that as you get stronger in that position. But anyways, the point here is that as my knees go forward, as I'm going down into a squat, it's producing ankle dorsiflexion and it's doing it eccentrically. That means my gastroc, my soleus, all my plantar flexors are working to control that motion. At the same time, my quadriceps and my vastus medialis, Rectus femoris, all the knee extensors are working eccentrically. And all the hip extensors, because I'm doing hip flexion, they're all working eccentrically. So they're all generating tension to slow things down. And then as I come out of this bottom position, it's that triple extension. It's going to be hip extension, knee extension, and don't forget ankle plantar flexion. Concentrically. And then again, flexion, extension, ankle dorsiflexion, ankle plantar flexion. So that's what's intended by 9, is to kind of get you to appreciate the movement. Now, let's go through this because I think it helps illustrate this eccentric and concentric function. If I lean forward, what joint action do you see happening here? If I lean forward, what joint action? And it should be ankle dorsiflexion, right? Now, if I were to ask you which muscles are responsible for doing this, the tendency is for you to want to say the ankle dorsiflexors because you said you saw ankle dorsiflexion happening. The problem is it's not ankle dorsiflexors, it's the ankle plantar flexors, because in this case I'm going with gravity, and if gravity had its way, I would continue all the way down and fall on the ground. So I don't have muscles that are really pulling me into ankle dorsiflexion. I have muscles, my plantar flexors, that are controlling me and holding me in this position, okay? Now, if I come from leaning forward and I start to go more upright again, as I go from here back to neutral, back to zero, back to normal standing, that was overcoming gravity. That was a concentric action. So that was also the ankle plantar flexors doing that movement. So the ankle plantar flexors were on here as I leaned forward. They were working eccentrically. They contracted to pull me back to an upright position concentrically. And now if I go back into ankle plantar flexion, now my ankle dorsiflexors are working because they are keeping me from falling back on my head. So as I move back a little bit, they are controlling me, decelerating me, kind of keeping me stable. And then as I return back to neutral, I'm going into ankle plantar flexion, but back to neutral, and it's the same muscles, ankle plantar flexors, that are working. And if I continue forward again, now it's the ankle plantar flexors that are working eccentrically. Now they're working concentrically, and now they shift roles. Now the ankle dorsiflexors, these guys are working because they're on this side of the axis. They're trying to keep this from So these guys are working now on this side of the axis, trying to keep me from going forward eccentrically. They're pulling me back against gravity to neutral concentrically, and then we'll do another cycle. They're going forward again. The plantar flexors are working eccentrically. Now they're working concentrically. And then here at rest in neutral, I should have very little muscle activity, or think of like a rocket in space, like a little space shuttle that just kind of, you get a little bit of a burst. Like if I start to fall forward a little bit, these plantar flexors turn on, bring me back to balance, and then turn off. And if I start to fall backwards a little bit, the dorsiflexors turn on and bring me back, right? So you kind of have this balance back and forth, but the muscles are trying to stay off to conserve energy. It's not until I really shift my center of gravity towards the outside of the base of support that these muscles start to come on and say, hey, let's get on board here to keep you from falling. Let's pull you back to neutral, right? And then these guys here on opposite, if it starts to come back, we're going to put the brakes on. We're going to decelerate you, stop you from falling backwards, and then we're going to accelerate you to bring you back towards upright position. So that's a great exercise to go through, a great one to review to kind of help you work your brain through concentric, eccentric activity. Want me to go through that again, or did you guys get that? Or are you just going to look at the recording later? So keep in mind, I do have all the answer keys for these lab sheets now. So what I will do, even if I still don't go over them, I'll provide all the answers, and you guys can go through and kind of check your answers, check your work. But I think I think 9 is a good one. I'm probably not going to give it to you in this form. I already kind of hinted to you that it's going to come to you in some type of triple extension, triple flexion, understanding this return from repositioning to positioning, repositioning to positioning, understanding the eccentric loading, what's happening, which muscles are involved, and then which ones are involved in the opposite. Okay. So 11, we're going to go to 12, but I want to just talk about 11 real quick, because 11 gets into what the activity wants you to do is it wants you to put your foot in a tub of water and then just look at your footprint. And your a footprint or foot analysis is actually pretty good. And when you look at this concept of pronation, when you look at concept of like pronation, supination, as I pronate, as my foot flattens out, it gets longer and it gets wider, right? Because what's happening is all the muscles are relaxing, the arch is collapsing, and it's taking up a bigger footprint. And then as I go through supination, as I start to overcome gravity, my arch starts to form and my foot gets narrower and actually gets shorter. So this is one of the problems with orthotics, is that you usually cast your foot in a static position, so you get a moment in time, but this is never what your foot looks like. Your foot is meant to spread out. Like if you take your hand and you kind of cup your hand and you spread your fingers out, think of like if you were to take a handprint and you put your handprint like this, and then you took your handprint like that, which glove size are you going to use, right? And if you were going to try to find a mitten, you would find a mitten that would accommodate you here, but then it would be way too loose there, right? But you'd be here. But if you did a mitten that accommodated you here, you wouldn't be able to spread out. This is one of the problems with footwear, with shoes, is that you get these really tight supported shoes and they really support your foot here, but then they prevent you from pronating. They prevent you from your foot flattening out. And that flattening out is the process of distributing forces and loads through all of these joints, preventing that from being connected throughout the chain. So what you were supposed to do in number 11 was just to see at rest in a static position what your foot looked like. And based on if you had more pressure on this side, or if you like analyzed someone's footwear or looked at their skin, if underneath they had more like calluses on the outside of the foot, you would say that they are a little bit more inverted. They're putting more pressure on the outside of the foot, versus if they had more calluses here, they'd be a little bit more everted because they're flattening out through that. Same thing with footwear. If you look at the bottom of the shoe and you're all worn out on the inside, you're putting more pressure or weight through the mid part of the foot, which means that you're inverting or collapsing at the arch, right? Or if it's more on the outside, you're more of the arch aspect. So it just kind of gives you a way of identifying foot function and foot diversity, but also being able to work through what may be happening and what's going on. Okay. So let's go through 12, because 12 is also a functional aspect. And I said, so with this exam, there's still going to be your decent amount of like which muscle attaches here, which nerve innervates here. But as I had said in the last couple aspects, I really want to focus this more on like functional analysis. Can you analyze movement and be able to identify which muscles are working? Are they working concentrically, eccentrically? As I had said at the beginning of this session, looking at passive and active insufficiency. How do you manipulate that to either isolate muscle function or maximize stretching of connective tissue? So there's going to be more of this practice. And so this one is definitely going to make its way on there of this whole like gait cycle, particularly climbing stairs up and down. And what it's looking at is looking at your descent of stairs or ascent, and you have reciprocal movement, right? So your front foot, your lead foot, your swing foot is doing something else than your post or your load foot. And let me look at this again. So when it looks at number 12, this is, you're going down a set of stairs and you're leading with your left leg. So your left leg's in the air and it's going out to step down, and your right leg is supported on that back step. And so if you think about what your back foot is doing, yep. So if you're here and your load's going forward, what's going to happen? What's happening here at the right leg? First of all, when you're leading with your left leg and you're going down the stairs, are you going down with gravity or going up with gravity? There's no trick question here. If you're going down the stairs, you're going down with gravity, right? So you're loading down. Okay. So most stair climbing on the way up is concentric and on the way down is eccentric, right? So this is going to be eccentric loading. So keep that in mind, because if you know it's eccentric, whatever joint action you see, it's going to be the opposite musculature that's controlling that. So if I'm going down the stairs, I'm dropping my, and this is my support leg, what should be happening? And it's actually this guy. I'm going down the stairs, I'm going into ankle dorsiflexion because I'm going into knee flexion, right? This leg is supported. And then as I step, as my left leg is going forward to reach down for the step, this leg is straight, right? It's actually putting out the landing gear and putting my toes down to try to here. So my change in my body height is actually coming from my support leg that's on the ground. And so I'm going through like that down phase of the squat. So if I'm going through that down phase of the squat, I'm doing knee flexion. So the tibia is coming forward. And what's happening is I'm rolling over the top of my foot, so my heel's popping up a little bit. So what joint action are you seeing that's happening here that's causing this motion to occur? You see ankle dorsiflexion. So that's what you're seeing here through the foot and through the midfoot, ankle dorsiflexion. That's happening eccentrically. So the muscles that are controlling that are the ankle plantar flexors. So the gastroc, the soleus, and the posterior tibialis and flexor digitorum. So I think I answered all of those except for the last one. I'm gonna type something here. Oh yeah. You're speaking to the choir here about barefoot running there, Douglas. So it's good. So the last part of this 11, part E, is asking if it's closed or open chain activity. And well, how would you answer this question? Is it closed chain or open chain? So it's both. The lead leg, the swing leg that's in the air, that's an open chain activity. Since the foot is on the step the entire time until the left leg closes the chain, this is a closed chain, and then it's only open chain is after you pick up this foot to make it to the next step on the way down. And just a hint, walking up and down stairs is very little difference than walking, right? So like loading, it's sometimes hard to appreciate the loading aspect of, are you anti-gravity or gravity during gait? but it's easier to visualize during stair climbing or stair ascent. So it's the right leg in this aspect is closed chain because it's on the ground, and then the left leg, since it's in the air going down to the next step, it's open chain. And then once that leg's on the ground and it's going through its loading cycle, the right leg is toe off, it's coming up off the ground, and now once it leaves the ground, it's open chain. And then once that heel hits, it's closed chain, and then open chain, closed chain, right? So whether you're trying to analyze open chain, closed chain, it's based on if the foot's on the ground or not. Let's go through the ascending of the stairs so you can kind of go through that. So you go to step up, you put your foot up on the step here, and you are here like this. You're kind of in a plantar flex position. You're hitting the ground and you are rolling over and then pushing off. And so this toe clearance in the air where you kind of in dorsiflex to kind of put your foot up, that's going to be your ankle dorsiflexors to try to clear the foot. And as your foot hits the ground, right, your leg's out in front of you, you are coming into ankle plantar flexion, knee extension. It's like doing a step up or a squat, right? It's the same thing. It's plantar flexors. So climbing a stair or going down the stair is the same musculature as doing a squat, which is the same musculature and same activity as doing a lunge, which is the same activity and musculature as doing a leg press, which is the same activity or of doing a single leg squat. It's all the same. Just that's why I said it's important to understand that when you're going with gravity, it's concentric, and it's going to be your plantar flexors, your knee extensors, and your hip extensors. And if you're going down with gravity, it's going to be eccentric, and it's going to be the same ankle plantar flexors, knee extensors, and hip extensors. The only time that you're really using your hip flexors or knee flexors or ankle dorsiflexors is when you are trying to pick your leg up, right? So if you're trying to step over a hurdle, right, which is a good example. You're trying to step over a hurdle and you're trying to pick your leg up to clear, you are doing hip flexion, knee flexion, and ankle dorsiflexion to clear that, right? But for the most of the time, it's the posterior chain that's doing a lot of the work. Okay. So the last thing I want to talk about is this. Oops. Is this? Am I still sharing my screen? No. I do want to share my screen, but I want something else. Okay, so when you look at the foot, you have the rear foot and you have the forefoot. And we said that the rear foot goes through its triplanar motion. You have ankle dorsiflexion, plantar flexion. And then when we look at frontal plane motion, we have that inversion and we have that eversion, right? So this is your right foot. And we said that the if you look at the bottom, the palm of your hand and the plantar surface of your foot, if the bottom of the foot's turning out, exit, that's eversion. And if it's turning in, it's inverting. And that inversion is coming from the subtalar joint that is right here, right below the talus, subtalus. And so you get this this everting of the calcaneus, of the rear foot. You also have your mid-tarsal joint that's right here, and it also can do inversion, eversion, but it can also do dorsiflexion, plantar flexion. But those combined movements is what gives you the ability to flatten your foot out through pronation or collapse and arch in supination. If my foot is not touching the ground and it's an open chain, the mid-tarsal joint, the forefoot, comes along with the ride for the rear foot. So if I do calcaneal or subtalar inversion, I'm also doing forefoot inversion. And if I evert the foot, the forefoot also everts. There's no differential there. If I'm on the ground now, however, and normally if I'm here and I try to invert, you can see that the toes kind of push through the plane of the ground. If this was like a soft surface, it would push that ground out of the way. And if I everted, the big toe comes down and in and pushes the big toe out of the way, pushes that part. So if you're on a compliant surface, you would yield, right? But you're on the ground and the ground doesn't yield. So when I do inversion of the rear foot, I can't push into the ground, right? So what ends up happening is it's the equivalent of me doing eversion of the forefoot, right? Because normally it comes along for the ride, but in this case it doesn't. And so if I let go here, it's the equivalent of me doing forefoot eversion. And if I do rear foot eversion and I stop that from moving because it's hitting the ground and I go back to normal, that's the same as doing forefoot inversion. So the way to look at this is in open chain, the forefoot and rear foot are doing the exact same thing. In closed chain, they're moving in opposite directions. And it's the same concept as the screw home mechanism with the tibia fibula. Internal tibia rotation is the exact same as internal femoral rotation. It's the same outcome, same muscle participation. Same thing here, forefoot or rear foot inversion is the same, and this is really not moving. It's not like this foot is just everting and it's producing muscle force. It's just not able to go along for the ride because it's hitting the ground. The ground's in the way, forcing the opposite motion to occur at that mid-tarsal joint. So just keep in mind when you look at like ankle motion, are you looking at open chain or closed chain activity? And just keep in mind that it's not the same for both. Like open chain, feet are doing the same thing, and closed chain, they're doing opposite. So it's two different sets of things to keep track of. Any questions? So you have a whole week to study more. I posted two things. I posted a quiz from my other kinesiology 236 class. I basically just posted the last semester's exam. So it's you can see the questions there. Some of the terminology might be a little off because it uses a different book, but the concepts are the same. So just take it through. You can take it as many times as you want. Once you submit it, it gives you answers. All of them are zeroed out, so they're not worth any points. So whether you take them or not, but I think it's a good practice to go through. I would take the quiz first, maybe study a little bit, then take the exam, and then see where your shortcomings are. I would go back and, I know you guys asked for a study guide, but I would, if you can go through the things that we highlighted during our lab time this unit, and the pre-lab and post-labs of this, and then the general questions at the end of each chapter, I think you'll be good. I think especially if you know the functional aspect, and that's what I was going to just propose how we're going to close today. We're going to close with page 257, number 16, which is basically analyzing squat. And we'll do it again one more time. What I'm going to do is I'm actually going to stop the recording and then start the recording again. So it's just this isolated segment of this aspect. So, but before I do that, I wanted to make sure there was any other questions. All right, so I